So like I said, if you weren't here earlier, the food is coming. It's a bit delayed, so it will probably be here when this case is over because it'll be quick because Kieran is so smart. He hates that. He's scared. All I'm saying is this is going to be Erin Dyer next year, 1 year out from the CPC. So you can pass off the torch. She's mad at me for saying that too. All right. Well, today we're going to be discussing the case of a 43-year-old male with past medical history of psoriasis and hyperlipidemia who's presenting with abdominal pain, nausea, and vomiting. So our expert clinician, 1 year into attending hood, maybe two, is going to be Kieran Patel. We're really excited to have him here. Just some info about him. He is now an instructor in medicine with the Division of Hospital Medicine. Also attends on firm, so you've probably seen him around. He went to med school at Drexel and then did residency and chief residency here with us. And I'll let.
So I figured I'd start with just my process of clinical reason. And this is nothing groundbreaking here, but I think just to kind of get us really anchored, I think the goal really of clinical reasoning is defining the problem. And that really comes down to trying to separate the signal from the noise. And then that way, if you can define the problem as accurately as possible, then you will get the right answer. Because if you have the wrong problem, you will inevitably end up at the wrong answer. So when I think about this a little bit more, there's two major things we need to consider is the patient and the clinical syndrome. So there's some specific patient factors I've outlined here, and then some specific features of the clinical syndrome I find very diagnostically helpful. So we can kind of talk about those in relation to this one-liner. So Millie gave us the age here of a 43-year-old gentleman. When I think of age, it can be somewhat helpful when we're on the extreme. Someone who's a little older, who's had time for chronic disease to develop and have complications from, maybe some medication side effects. And then when you have someone younger, I think much more about like genetic syndromes that are starting to manifest or some sort of environmental exposure, whether that be unhealthy or unsafe behaviors. But you gave me someone who's 43 and smack dab in the middle. So I don't find that terribly helpful. I think it could be either someone presenting a little late from a young type of process or someone who's kind of presenting a little bit earlier. So moving then into the past medical history here, obviously psoriasis catches our attention. And I don't know if I can really link psoriasis directly to an abdominal syndrome, but what we do know is that autoimmune disease in general increases your risk of having other autoimmune diseases. And so the one that immediately jumped to my mind was something like inflammatory bowel disease. So we have to kind of remain concerned that there could be a new presentation of an autoimmune condition here. And then hyperlipidemia, I would normally glance over this when I'm reading a chart, but given that this person is chronically inflamed, that definitely increases their vascular risk. We know with people like, for example, with rheumatoid arthritis, they tend to present with coronary syndromes a lot earlier. And so could this be an atypical presentation of an MI? So something to consider. And then obviously with psoriasis, you worry about, is this person having a real bad bout of psoriasis? They've been on immunosuppressing medications for many years or even recently, and could that be influencing their immune state? And then I always worry about toxicities. For example, if this person had recently been exposed to prednisone, could they have a peptic ulcer that's, now maybe perforated? We will find out, I'm sure. So the social history, obviously, I always think is very important, really adds color to the case. So now getting into the meat of this here, the clinical syndrome. So I would say, Millie didn't give us time course here, but I think time course is probably the most powerful thing you will ever have when you're doing medicine and trying to diagnose someone. And really, if you can kind of think of this on two ends of the spectrum, if something's very hyperacute, that to me means I don't have a lot of time to figure out the answer. I'm often managing and treating and trying to diagnose at the same time. So I'll be very, very interested to know the time course of this syndrome, because if this has been indolent and going on for 6 months, that totally changes how we think about it versus if this is sudden onset and he's presenting directly from home after this symptom started. In that same vein, severity is helpful in terms of a localizing factor and also kind of pushes us towards what we need to do first. If it's less severe and it's more chronic, I know I have more time to think intricately about the case and do a nice workup before we do any sort of interventions. But the more severe and acute it is, the more rapid we have to act. And then obviously I'll be looking for any localizing symptoms. So abdominal pain, nausea, and vomiting, incredibly nonspecific. I can't even imagine the number of diagnoses I can think of that would cause these symptoms and not be localized to the GI tract. So for example, DKA, adrenal insufficiency. So the GI tract is often a bystander in disease and not actually the focus and the center of gravity here. So I'll be looking for other features in the history that actually have higher specificity, like blood in the stool. That would really make me much more concerned about the GI tract than what you gave me here. So thanks for a lot, Millie.
You're welcome.
And then finally, you can think about abdominal pain in a lot of different ways. The clinical problem solvers have this schema out. I think it's one we're most familiar with. It's basically an anatomic approach to abdominal pain. Millie didn't give us any information of where this pain is to start, but I think the one thing I'd like to highlight is the life-threatening things. So I usually think about this in terms of like VIPO, so vascular issues, inflammation or infection, some sort of perforation or obstruction would be the things I want to make sure we're not missing before I dive deeper into trying to figure out what's going on.
Perfect. Well, let's see if we can answer some of your questions with a history. So the patient endorses 24 hours of abdominal pain associated with nausea and vomiting, also endorses subjective fever and chills. Last night, he notes 2 to 3 episodes of bloody diarrhea. He recently traveled to Colorado. There, he started to notice a rash that started on his legs and moved to his arms and torso. And due to the rash, he went to the great urgent care, who said, I don't know, steroids and an antibiotic.
So you gave me all my worst nightmares here. So I think first the time course here. So 24 hours here really like raises my concern that this is something more severe, and we have to be really open to those 4 things I talked about: a vascular issue, an inflammation or infection, a perforation or an obstruction. So it's that until proven otherwise in my mind. The presence of fevers and chills, were these all within the past 24 hours as well? So, there's not many infections that will really kind of present this acutely. Usually it's like you have a couple days of like an evolving clinical syndrome. So the fact that this is rather short kind of narrows things a little bit. So I usually think of like pus under pressure or something suddenly getting obstructed, like a cholangitis picture could present this quickly. But this wouldn't be great for like Rocky Mountain spotted fever, given the fact that he's recently traveled to Colorado, but I won't eliminate it just yet. But I'm thinking more, maybe this is not infectious, just given how quickly it is, aside for cholangitis. The bloody diarrhea, I think, helps tell us we're probably firmly in the GI tract here and something we're going to have to evaluate. Blood plus pain for the GI tract really tells me that I think I'll be able to find the answer with a CT scan, and rather than just like doing an endoscopy alone. If it was non-painful diarrhea, bloody diarrhea, I think a lot of those times those CT scans tend to be normal and you're just dealing with like your, random GI bleeds. But this looks like inflammation and bleeding. And so like, my thoughts about an IBD flare and something like that certainly kind of continue to percolate in my mind. I don't know really what to make of the Colorado trip. I'll just kind of track it for now, but I'm not going to put too much weight there. The rash is incredibly interesting. I hate rashes. Thanks, Millie. One question I would have, and I'd be trying to get a better sense of, is how has this rash evolved? And when the exact timeline of the rash? So was the rash preceding the symptoms?
Yeah.
Okay. And how long has the rash been present?
Couple of weeks.
Couple of weeks. Okay. And how did it evolve on his body? It started on his legs and then moved upwards.
Correct.
Okay. Interesting. So a lot of the rashes I think about immediately, like measles and things like that, tend to be descending rashes. This sort of ascending rash is a little bizarre. I guess we'll wait to the physical exam before I elaborate more on the rash. And then, of course, he goes to urgent care, gets steroids. I think his syndrome was already well on its way before he arrived there, so I won't take much more time thinking about the steroids or the antibiotics as a potential side effect here.
Cool. So just some additional information. So the patient states they actually went to Mexico as well about 3 months ago and had food poisoning there after eating street food. Not really sure if it's related, but thought he would say that. Also had some rhinitis and cough a little over a month ago, which is now resolved. but no recent sick contacts.
Okay. So the infectious disease differential broadens again. I know Miguel's here, so luckily I can call a friend if I need help, but I don't know what to make of that too much. 3 months ago, without any really, I mean, the rash is interesting. So I don't really know how to connect those dots just yet, but something I'll definitely worry about. There's definitely certain things endemic to Mexico that we don't have here, but common things being you're really in the realm of esoteria if you're looking at 3 months out, right? This isn't going to be Giardia probably at this time frame. So something more unusual or atypical from an infectious process could be entertained, but I don't really know just yet. The preceding viral prodrome, the only thing I really think of here is like a post-strep process where you can get a rash. I don't really know how to link that into abdominal pain right off the bat, but maybe some sort of complication or progressive syndrome with this upper URI symptoms. I guess the other thing that comes to mind would be something like Wegener's or some sort of vasculitis, something that's multi-systems. And I guess the question I'd have is the rhinitis and cough completely, it is completely resolved. So
Yep.
yeah, maybe something more like a post-strep, something that has come and gone and resolved would be something I'd think about with that bit of data.
Cool. Well, let's just round it out here. So we talked about past medical history already. Otherwise, no pertinent surgical history. Had a brother and has a daughter with celiac disease. No allergies, only takes Flomax. And then in terms of social history, lives in St. Louis, drinks 1 alcoholic beverage per week. No history of tobacco or illicit drug use, no pets, and then sexually active with 1 partner.
So I think this is helpful. So it seems like his psoriasis is pretty well controlled and maybe just managed with, very minimally topical agents. So that I think that's helpful. So he's not immunosuppressed, that's obvious, but we still remain concerned that his history of autoimmune disease makes him at risk for other autoimmune diseases. I don't make too much of his family history here. He's young enough that anything is still on the table. Flomax, I don't think really is contributory here. I think the social history stuff that was interesting, you already gave me his travel history, so I won't kind of waste too much time here because it seems like we'll have a lot to unpack.
Cool. And then in terms of review of systems, fevers and chills we mentioned, intermittent epistaxis, but nothing recently, but has had that in the past. Just seems like less related to maybe like a systemic process. I'll be nice to you, and more related to just like dry nose. And then abdominal pain, nausea, vomiting, melena, hematochezia, like we mentioned, and then also mentioned the rashes already.
Yeah, perfect. So I think this just kind of confirms everything we've already been saying. And so now thinking about what am I really going to be looking for on exam? So this guy's coming in with a rather acute abdominal syndrome. Like I said, I'm really worried about the GI emergencies. So I'm really doing a very thorough abdominal exam. I'm trying to convince myself not to call for help when I'm seeing this patient. So I'm really looking for any evidence of obstruction. If there's pain out of proportion that could suggest a vascular issue, or if there's, peritoneal signs that could be more, or air in the abdomen that I can percuss, I'd be much more concerned for like a perforation. So I'd be looking for that. And then the rash specifically, I think probably the most helpful feature is what does it look like? And then the distribution, if there's any areas of ulceration, and then whether or not like we can kind of get a picture of that would be helpful.
Cool. All right, so this is what I have in terms of physical exam. I don't have a picture for you. That would be too easy. So we have vitals there, look pretty good. Otherwise, the abdominal exam was documented as diffusely tender to palpation. So not very helpful for you there, but no rebound tenderness or guarding. So that's reassuring, I would imagine. And then in terms of skin, so they said purple, non-blanching, violaceous papules across feet, legs, torso, and arms, slightly pruritic, non-bleeding, and non-tender to palpation.
Okay. But he's comfortable and not acute distress when you're examining his abdomen.
Correct.
Okay. Well, still worried, but I guess that's somewhat reassuring that, maybe we don't need to fire up the CT scan right away, but there's no way I'm not putting this guy in the tube of truth at this point. So the skin, the rash is actually really helpful here. So palpable purpura in my mind automatically becomes leukocytoclastic vasculitis. So we have vasculitis now. And I think that's something we can really anchor ourselves on. And now I'm trying to think through what causes vasculitis. And the first things that come to mind are, well, how do we think about vasculitis? You have large vessel, medium vessel, small vessel. Large vessels typically are the aorta and the branches off the aorta. That doesn't really present like this. And those typically don't really cause rashes that would appear this way. Medium vessel, it's still kind of possible, like your polyarteritis nodosa, but then again, the rash is a little bit different. It tends to be more nodular. You might have more of a livedo type pattern to the rash. And then sometimes when it's really bad and there's ischemia, you have like more ulcerative lesions. But here, this sounds like the rash is relatively small and raised. And so I think we're firmly in the bucket of a small vessel vasculitis now. And then, so this would be the palpable purpura. So how do we think about small vessel vasculitis? It's either a primary process or a secondary process. And I think most times we worry about the ruling out secondary processes off the bat, and that would be infections, autoimmune diseases, malignancies, and drugs. So what infections do we really worry about? We worry about HIV, hepatitis C specifically with its association with cryoglobulinemia, hepatitis B as well. There are other viruses, but those would be the ones at the top. Then bacterial infections, really staph and strep are the ones I worry about here. So endocarditis could definitely present in this way with a cutaneous vasculitis. I guess post-strep, I'm not too sure. I'm not sure I've ever seen post-strep, but post-strep, I guess, theoretically could also present this way. And then in terms of malignancies, it would be more like a liquid malignancy, and then the secondary manifestations of a cryoglobulinemia from that. Given his age, I don't think that's really on the table. Now, autoimmune disease is interesting still. I think the ones I really worry about would be RA and lupus. And so I think those would things we'd have to entertain for. So getting an ANA, getting a rheumatoid factor, maybe a double-strand DNA as well, and ENA would be things I'd be considering. So where was I? So, and then drugs. Like there's a whole host of drugs. Tamsulosin, I don't think is one that I associate with a vasculitis, so we can kind of check that off our list. So that's predominantly the secondary causes we worry about, but then you have primary causes of vasculitis. So this is you can break this down in terms of small vessel vasculitis into two things, really, ANCA vasculitis and then immune complex mediated vasculitis. So could this guy have Wegener's? Could he have EGPA? Could he have MPA? It's certainly possible. So I think I'd be wanting to send off an ANCA pretty quickly here. And then could this be immune complex mediated? I'd send off complements because I think in that bucket, depending on what the complement levels are, kind of helps you differentiate. So how can we link vasculitis to abdominal pain, acute abdominal pain? I'd really be worried about a vascular process here, some sort of ischemia to the bowel specifically. So I'd be really interested in getting like a CTA here. I'd be sending off blood cultures as well. So I think that's where I'd go. And I think what you've noticed here is I just latched on to something I'm very familiar with, which is vasculitis. And I think that's what we tend to do, right? We find something that's highly specific, and then you try to marry that with whatever you feel most comfortable with, like in your mind. So that's where I'd start. Definitely basic labs, really searching for a secondary cause of his vasculitis that we're seeing on exam.
Cool. Well, let's start with some basic labs.
Okay, so when thinking about vasculitis, Dr. Chang's here. We always worry about the kidney. The kidney, and normal creatinine does not rule out renal pathology here, so we still would want to get a UA and assess for any blood or protein in the urine. Going through the rest of the chemistry here, there's not a whole lot helpful or that really grabs my attention. The CMP, again, not too helpful. I noticed that the ALT is a little bit high. I don't know what to make of that in someone who's systemically inflamed with a GI syndrome. But maybe I feel a little bit better that this might not be cholangitis. The white count being elevated, the diff is normal, so it's predominantly neutrophilic. So, infections are still on the table, but anything with inflammation, like we've been saying, would be a concern here. So still interested to get an autoimmune workup, blood cultures, viral studies, to kind of help assess for those secondary causes of a small vessel vasculitis.
Cool. You mentioned the kidney. Got a UA for you.
So the urine dipstick is not perfect. It's really good as a screen, but when you screen for protein, it's only really detecting albumin. It doesn't detect small light chain proteins. One of the things we kind of entertained were malignancies. The ones you'd worry about with a small vessel vasculitis would be like a monoclonal process that's then secondarily causing a cryoglobulinemia. So if you were really worried about that here, this doesn't necessarily make you completely less concerned, but I'm not really getting the sense that that's something I would really chase at this point, especially given that the blood is rather unimpressive here at this point. So I don't know, Dr. Chang, if you feel that the kidney has been exonerated, but I feel reasonably okay at this point.
Give you the thumbs up. It's pretty good. All right. Got some micro studies for you.
Okay, so negative RVP, pretty much negative across the board. So this is helpful. The acute hepatitis panel is negative, notably. I think that's probably the most helpful in the HIV and the blood cultures. Those were the things I was really worried about. Now, Rocky Mountain spotted fever, like we said, that could do something like this theoretically, but I think the time course doesn't necessarily make the most sense. So I think this is helpful in maybe moving us away from secondary and more into our primary buckets of small vessel vasculitis. So still waiting to see the complement levels and the ANCA testing. And then I'd still want to know what the ANA rheumatoid factor and like kind of his secondary workup for risk factors for autoimmune disease. I guess the other thing that just came to mind, I did bring up the possibility of IBD up front. When I think of rashes associated with inflammatory bowel disease, I don't think of a small vessel vasculitis. I think more of like erythema nodosum, and I think of like pyoderma. So I guess it's possible. I'm not really aware of a small vessel vasculitis associated with IBD, but I guess that's still on the table. So one other thing you may consider is like trying to get a sense of it. I mean, we know this guy's GI tract's inflamed, so I don't think a fecal calprotectin is going to be terribly helpful here, but maybe a CT scan, which I'm still waiting for, by the way.
Next, I'll give it to you. We'll
So
see if that helps you.
Yeah, the inflammatory markers aren't that impressive here, surprisingly. I guess I would have expected them to be higher. I don't know if his prior exposure to steroids changes this a little bit. But something we'll have to keep in mind. They're not terribly sensitive and specific, so I don't think I'd make any dramatic management decisions or diagnostic decisions off of a CRP or ESR, other than if they're very, very elevated, then maybe I'm more concerned in certain disease states. But here, I don't think it really makes me feel any more comfortable. Are those complement levels normal?
Yeah.
Normal. Okay. So I guess with normal complements and small vessel vasculitis, you start to entertain HSP, Henoch-Schönlein purpura, which is now called IgA vasculitis. I think it can be associated. Is that an IgA level elevated?
Normal.
Normal. Okay. I don't know if it affects the systemic IgA levels at all, IgA vasculitis. That would be something I'd be Googling for sure to try to figure this out. Obviously, I'd already be calling for a lot of help in this case, but now the ANCA is negative. ANCA is not a perfect test. You can definitely have ANCA negative vasculitis. I think that's most common with GPA, which was the one we were most concerned about given kind of the URI type symptoms. I guess I'd ask Dr. Chain, how common would it be for GPA not to affect the kidney with this degree of systemic involvement? So I guess it's still on the table.
That would be so mean. Can you imagine if I did that to you?
I can believe it. I can very much believe it. So I guess the things that are really still on the table, if we think about that schematic I laid out in my mind earlier, are an ANCA negative vasculitis and an IgA vasculitis. I don't see cryoglobulins here. That can be idiopathic, but I would expect usually in cryoglobulinemia that the complement levels are low. but I guess it could still be normal. So I'd be curious about what the cryoglobulin levels are as well. But I'm thinking maybe an ANCA negative vasculitis, IgA vasculitis. And then there's still a possibility here that there's two things going on, because he seems sick. He seems reasonably sick based on your exam. So there could still be some other things. So I'd want a CT scan as well.
Let's get the CT scans. We have Dr. Rajput from radiology here to walk us through it.
Oh, no, it's fine. The arrow should be fine. Okay, so this is the CT scan, the one and only CT scan the patient got through the ER. So you're seeing here a segmental loop of small bowel that is abnormal compared to the remainder of the bowel loops. You can see some of them here that look normal, and then this one in particular is abnormal. It's a considerable length of bowel involvement. It's not focal like what we might see with a mass, but it's inflamed. You can see that there is the mucosa, which is hyper enhancing, and then the submucosa, which is hypo enhancing or hypoattenuating, indicative of edema and active inflammation. So this is clearly in an abnormal bowel loop, and then we see adjacent to it some engorgement of the adjacent mesenteric vasculature with some fat stranding and these lymph nodes in the mesentery that, although they aren't pathologically enlarged, they are out of proportion to what we would expect for other lymph nodes, non-enlarged lymph nodes in the mesentery. So they're probably reactive in some nature to what's going on with the bowel. And then looking a little bit more proximally, we can see that there are some small bowel loops in the upper quadrant here. These are more proximal jejunal loops. And if you look carefully, it's kind of subtle. You could even do, I don't know, does that help? No, that does not. Maybe that helps a little bit. But this is an area where the bowel is kind of telescoping into itself. So there's an area of bowel here that's telescoping into an adjacent loop of small bowel in the left upper quadrant. And another one, this is these are two separate ones here, another area of telescoping of bowel into one another. So this is what's called an intussusception. Now, these are short segment intussusceptions that aren't causing obstruction. It's difficult to say whether or not there is a mass there. Oftentimes you need more specialized testing, such as a small bowel enteroscopy or CT, or more likely MR enterography to determine whether that is a mass there or not. But they're very short segment. We don't see an obvious mass here, but we think that they're probably related to what's going on with that additional inflamed small bowel loop in the right lower quadrant.
And so I guess, unpacking this a little more. So this bowel is very concerning here for it. Would you say a vascular injury?
Yeah.
Like how do the vessels look?
Yeah. So the vessels, the large vessels I don't show them, but they're completely normal. The aorta is normal. The SMA, the celiac, the IMA are all widely patent and normal. There's no irregularity of the vessels that may suggest either a large or medium vessel vasculitis. There's no perivascular thickening or soft tissue that is also supportive of that. But it could still represent a small vessel vasculitis. And the differential for this, unfortunately, is pretty broad without the clinical context. So with the clinical context, you can start putting things together, and certainly vasculitis can look like this. Other things that you could consider in the absence of that clinical history would be just run-of-the-mill infection, potentially some severe infectious enteritis. IBD would be a possibility as well, but again, this is all just in the realm outside of the clinical history. Small bowel angioedema related to ACE inhibitor is another possibility. and lupus in the spectrum of vasculitis, those sort of things. Other thing, graft versus host disease, if the patient had had a bone marrow or a stem cell transplant, those other things could look like this. But yeah, when you combine the two, certainly small bowel vasculitis is still at a consideration.
So I guess the other thing that came to my mind while you were showing this, obviously IBD, I think starts to raise back up my differential here. And then I'd be furiously Googling whether or not that's associated with a small vessel vasculitis as well. And then the other thing was with the lymphadenopathy, I didn't hear you say, and I don't see, though these are inadequate pictures to assess for any splenomegaly, whether or not this could be like a GI related lymphoma as like a lead point, and with the lymphadenopathy, whether that could then be associated with like a cryoglobulinemia potentially. Just because I don't know how to think about these intussusceptions. Like you said, they're usually caused by lead points. And so I'm trying to link, could he have colon cancer? Could he have like a GI lymphoma with like, I know in like kids, you have like the Peyer's patches, which is that inflammatory, basically immune tissue that when it gets hypertrophy can become a lead point. So whether or not there's like some lymph nodes that are leading to this as well. So I think malignancy, IBD, I think we still have our small vessel vasculitis. I guess IgA is still a possibility. It definitely causes intussusception in kids. I don't know. I mean, the whole disease entity itself is way more common in kids. I don't know if I've seen a case of this in adults, but I'd be also looking to see if that could be causing a presentation similar to this as well. So I guess where would I go from here? The CBC was not too remarkable to suggest like of a liquid malignancy. So I'd be calling our GI friends and maybe surgery as well to kind of evaluate this, to query the question of what do we do about these intussusceptions and this ischemic looking bowel potentially? Is this IBD? And then I'd probably call derm to biopsy the rash as well. I think that'll probably be a pretty definitive test as well. Oh, perfect.
Yes, you called up, forget surgery and GI, you called up your friendly dermatologist and they got a great sample for us. So I'll have Dr. Bloma walk us through the dermatopathology.
So just one quick point. So I guess this would be of the IBDs, you'd really be entertaining Crohn's disease, which is a granulomatous type inflammation. I don't know if that then carries over to the type of inflammation it causes in the skin. So I'd be curious if there's granulomas.
So the dermatology service performed 2 punch biopsies, one for H&E and one for direct immunofluorescence. This is lower power of the H&E, and you can appreciate that there's a perivascular inflammatory cell infiltrate. It doesn't appear to be granulomatous at this power, but we do have higher power here. You can see that the inflammatory cell infiltrate consists of lymphocytes, histiocytes, neutrophils, as well as eosinophils. A little hard to appreciate with the color of this stain, but there is also red blood cell extravasation. The endothelial cells may appear a little bit plump here, but there was no overt evidence of fibrinoid necrosis of the vessel walls in this specific biopsy. So very helpful here was the direct immunofluorescence. So you can see here in the, it's kind of, let's see, is there this up here is the epidermis. And if you, basically you want to be looking for the areas that are much more brightly staining. So you can see that there are some foci more brightly staining, and this is actually IgA deposition in the superficial vessel walls. We also noted C3 deposition in the superficial vessel walls, as well as fibrin. IgG and IgM were not deposited. So this was signed out as a leukocytoclastic vasculitis, early lesion probable. It's also possible that the steroids might have influenced the biopsy because we didn't see that fibrinoid necrosis, but the inflammatory cell infiltrate, the red blood cell extravasation all led us to feel it was a leukocytoclastic vasculitis, and the direct immunofluorescence was very helpful And we wrote that it could be compatible with IgA vasculitis in the correct clinical setting.
Could be, great, could be. Well, I think that's very helpful. Could IgA, I guess the question, the things I do at this point is can we link everything we're worried about to IgA vasculitis? And is there anything else I need to be worried about here before I move forward with that thought process? I feel like it definitely could cause, we obviously have vasculitis. I think this is essentially as good of a diagnostic test as you're going to get for IgA vasculitis, I think. So I feel pretty confident with that. Now, could that then explain the GI symptoms? Well, I think it's not inconceivable to make the leap that, well, if this happens in kids, theoretically could also happen in adults. So I think it explains his GI symptoms. And I'm not hearing anything totally convincing for a malignancy or another autoimmune disease at this point. I'm not sure if you have any other information or if I have to make a guess here. But I guess this would be probably most consistent with an IgA vasculitis.
Let's give Kieran a hand. All right, some brief hospital course here. So evaluated by derm, continued on a steroid taper until outpatient follow-up. The intussusception resolved without surgical intervention and then referred to room in the outpatient setting. So like you were mentioning, this is primarily a pediatric disease, but it can occur in adults, although it is rare. Primary presenting symptoms include arthralgias, abdominal pain, and this rash. And the primary complication is renal injury. So I think Dr. Chang was actually consulted on this patient and said that they didn't need a renal biopsy or anything like that. But it is a complication of the disease. And then intussusception is incredibly rare in adults. So there's only a few reported case reports. So Eric Mittauer is actually writing this up. So really cool. And treatment is mainly supportive care, although patients are sometimes given steroids. So let's give Kieran another round of applause. He'll definitely be back next year. So future chiefs, hit him up.